feedback and responses throughout. We will have time, as I was just saying, for that moderated discussion. So those of you in the room as well, hold on to those questions, and I'll come around toward the end of the hour. And then second, for everybody, both in the room and online, we hope that you'll take a minute at the end to fill out our evaluation. There's paper copies in the back, and it'll go in the chat toward the middle or end of our discussion today. For those of you in the room, if you haven't yet, there is lunch in the back, and we hope that you will grab one and enjoy. All right. A couple other announcements before we dive in. We have a few other upcoming events we hope you'll join us for. On Wednesday this week, we have Transforming and Advancing a Learning Health System. This is part, I think, 3 in our series. We will hear from Dr. Kawamoto on enabling a learning health system, the experience of University of Utah. And then in February, as part of that same series, we will have a panel on value in learning health systems. In March, we have a special guest from Vanderbilt, Sunil Kripalani will be here with us. And then in April, we will wrap up the end of that series with next steps in a learning health system. In May, we will have emerging topics in digital health and clinical informatics, part of this series, and we will hear from Matt Liscalzo from City of Hope. And then if you don't already have it on your calendars, CopperCon is June 4th and 5th. That abstract deadline is this Wednesday. We would love to hear from you and be able to share some of your work. And registration will open soon this month. All right, on to what we all actually came here for today. Today's seminar is part of our Emerging Topics in Digital Health and Clinical Informatics series, and we welcome Dr. Matthew DeCamp. Dr. DeCamp is an associate professor in the Center for Bioethics and Humanities and Division of General Internal Medicine. A practicing internist, health services researcher, and philosopher, Dr. DeCamp employs empirical and conceptual models to identify and solve cutting-edge problems at the interface of healthcare, policy, and bioethics. He has a special emphasis in his research, including ethical issues in artificial intelligence, engaging patients in healthcare organizational decision-making, and in global health. And he serves as the Director of Research Ethics for the Clinical and Translational Sciences Institute. Please join me in welcoming Dr. DeCamp.
Great. Thanks for the introduction, Sarah. Thanks for the opportunity to be here and talk about ethics and bias in artificial intelligence. I hope that this will be sort of engaging and have plenty of time for conversation at the end for questions that you might have. So hopefully spur some conversation through this. I will talk a little bit about some of the funded research studies we have in AI. We have an R01 looking at AI-based mortality prediction. We just finished up a Greenwall Foundation grant on patient-facing chatbots in healthcare. I'll talk about that. We also have an R25 training program with Drs. Flores and Yang called Heart Bio that's at the intersection of omics, science, and includes bioethics as well as AI. So I'll talk about some of those as we go along. No conflicts to disclose. And when I mention any kind of products or LLMs or AI technologies, that's just for illustration. It's not any kind of an endorsement. By the end, I hope you'll understand that there are really 3 sources of bias in AI models in healthcare. We'll be able to compare and contrast different fairness metrics that can be applied to AI-based models. I think this is the future of AI, is the use and application of fairness metrics, specifically around bias. And then I'll hope that you'll be able to discuss how bias affects some of these other key ethics issues for AI and research, education, and practice. I sometimes say bias is not just an issue for data science and AI. I think bias is the issue. Bias is the issue that explains lots of other problems we have with AI and machine learning in healthcare around consent, transparency, privacy, and so on. Although today we'll be focusing mainly on bias. I'd like to start out with just a primer on what AI looks like in medicine, to talk a little bit about the technologies so we're grounded in what these things actually do. This is generative AI. It creates pictures from prompts, and I asked this generative AI to depict the future of medicine. And this is what it came up with only those 4 words. Give me a minute to look at it. I did check. I had correctly spelled the future of medicine, even though the AI didn't spell it correctly in the upper left of this image. I'm not sure what organs are actually depicted behind this person. I'm not sure why this is the person that was depicted, and I don't know what to make of that hand gesture either. And then if you look closely, the hand has 6 fingers. So shocking in terms of what it can do based on only those 4 words, but also shocking that some of the errors it seems to make. Generative AI has particular problems with hands, it seems, although of course some people do have 6 fingers. You can ask AI also to describe the future of medicine in words. So this is, again, generative AI. What will the future of medicine look like with artificial intelligence? And it does a pretty nice job at generating a lot of text, again, just from that question: personalized medicine, diagnostic accuracy, drug discovery and development, predictive analytics, virtual health assistants, as we'll talk about with Livy, the patient-facing chatbot. Interesting text that we see here, but probably not as interesting as if we ask the AI to rephrase what it just did in the manner of Dr. Seuss. Now the AI says, in the future of medicine, oh, what a sight. AI will dazzle with all of its might. With data and digits, it'll help us each day in marvelous, magical, and marvelous ways. So it's simply reframed all this prior text that you just saw here into the format of a pretty good, I would say, Dr. Seuss poetic style, illustrating the power as well as some of the peril, I would say. I'll point out that at the very bottom of this, I like it that the AI points out, with privacy and ethics, it must stay acute. In the world of medicine, bright future we see, thanks to AI's magic as grand as can be. So I love the nod to ethics here, and ethics in AI, even in this example. This slide just gives you a sense of the applications in AI in medicine. They're already here across very diverse domains in medicine: cardiology, endocrinology, radiology, of course, in the green, a popular place for AI to do image interpretation and so on. This is now outdated. As of last fall, the FDA had authorized, not strictly speaking approved, authorized is the better term, had authorized more than 900 AI-enabled applications in healthcare. So clearly a rapidly expanding field and a wave of AI that some would say is already here. When it comes to research, this graphic on the left just shows you the 6 basic steps of the scientific method, from asking a question, developing hypotheses, analyzing data, reporting on the results, and so on. And already today, you can do every step of this. Every step of this method can be replicated and done using AI, literally asking questions, analyzing data, and reporting results, asking AI to write journal articles. I'm not saying you should do this. I'm just saying that it's possible to do all of these things through AI technologies that currently exist. Also, of course, in education, this is just one example of a study where AI did very well, it turns out, on the US medical licensing exam. It's passed these exams. It's been used for questions. Medical education is using this a lot. There's even a program out there called Open Evidence, I believe, that uses AI to generate responses to scientific literature queries. AI is not really new, and I think it's helpful to understand the overall spectrum of AI, even as it compares to data science. Artificial intelligence has been around for a long time. In the 1970s, there's a program known as MICEN. I was fortunate enough in our clinic to work with a nurse who had been one of the developers of the MICEN program. And MICEN helped clinicians diagnose and treat bacterial infections. Now, this was rule-based AI. You like to think of it like a flow chart. It goes through rules and comes up with a recommendation based on rules. So it's AI, it's trying to mimic human intelligence, but in this case, it's doing it through rules. That's not what most of us are excited about now. It's not the rule-based AI, it's these other forms of AI, things like recommender systems. If you use Amazon or Netflix, then you've interacted with machine learning as a subset of AI. Netflix claims that 80% of the choices made about viewing are influenced by its recommender system. Beneath that is deep learning, a subset of machine learning. If you've used translation, chatbots, as we'll talk about, facial recognition, those are forms of deep learning. And then, of course, there's generative AI. I've already showed you this, generating that response to the future of medicine, either in art or in prose. That's generative AI, again, a smaller subset. So this gives you a sense of AI. Now, there may be real data scientists online or here who would do a better job at explaining how AI works, but I'd like to make sure, again, we're level set on what these technologies look like because it sets the stage for how we think about ethics and bias. So we might ask a question, how does AI learn to see? How do these image interpretation platforms work? Well, imagine we had a seemingly intractable biomedical problem. How do we sort blueberry muffins from chihuahuas? And we want to do it using AI. This has been on the internet for a while, but I think it's a great example of this particular type of AI. We're going to use an AI image analyzer. We're going to show it pictures and categorize that's a blueberry muffin and there's a chihuahua. Now, we probably have a gold standard supervisor. That could be you or that could be me. And we stand over this and we decide, oh, that's correct, or we correct it when it's incorrect. And then we just start showing it lots of pictures. Blueberry muffin, chihuahua. There's a chihuahua, blueberry muffin, chihuahua. They do look alike, don't they? Not an easy problem to solve until eventually it gets one wrong. And then we say, we'll correct it. That's why we have a supervisor in place. Now, of course, if you understand a technology like this, you can imagine that if we showed it a picture of a St. Bernard, we might not know what it's going to come up with. Is it going to characterize it as a blueberry muffin or a chihuahua? And of course, neither is correct. This brings up the point of AI behaving differently in unfamiliar environments, right? You show it something it's not seen before, it's very hard to predict what it will come out as an interpretation. How about these predictive analytics, AI predicting the future, as we'll talk about with AI-based mortality prediction? I think we're all familiar with the idea that you can use data points like height, weight, blood pressure, and so on within an EHR to predict future disease risk, heart attack, stroke, cancer. Well, now what happens when we have millions or billions of these records? We follow patients over time and ask this question, what factors predict things like cancer, stroke, heart attack, and so on? The power of AI is that we have the ability to identify new factors, things that we hadn't seen before, and hopefully come up with better predictions through the power of data, big data, additional data that we haven't had before, as well as the computing power itself. Those are predictive analytics. Lastly, ChatGPT. The chair of Department of Biomedical Informatics, Casey Green, likes to analogize ChatGPT or these generative models as fill in the blank. And we all know what comes next in a particular sentence. I've heard Casey also say that ChatGPT or LLMs are sort of like that annoying friend at your party who insists on completing your sentences for you. That's in essence what ChatGPT and LLMs are doing. And you might say, well, how do they do this? Well, these models have been trained on lots and lots of text from the internet, text from books and articles, with a little smattering, again, of human oversight that was done in the early phases of training these models to come up with a prediction of what comes next in the sentence. And the power of it, go back to that example, the future of medicine. That's the only question I gave the large language model was, what does the future of medicine look like? And yet it generated what looked like around 750 words of text in response, all based on statistical prediction. The common thread between these methods is that the AI is only as good as the data that are used to train it. And this is where we're going to enter and have a discussion now about bias. Only as good as the data that are used to train it, whether it's the pictures and you show it a St. Bernard, whether it's the text and where did the text come from, or how good are the data in the EHR to make those predictions as well. So what about AI and biases? So if we step back from a philosophical perspective or from an ethics perspective, we like to think of bias as any systematic unfair weighting of a person, a thing, or an idea. So we have a very broad notion of what counts as bias. And it's important for us to keep that in mind because it'll help us diagnose the problem of biases in AI models. In fact, we see examples of bias that align perfectly with those technologies I've already shown you. This is AI-based chest X-ray interpretation, where we ask the AI model to do things like diagnose pneumonia, diagnose fluid in the lungs, and so on. Look closely at this model, and you'll see that it has significantly more underdiagnosis in people who are female, of Black race, of Hispanic ethnicity, on Medicaid, or those who experience intersectional disadvantage. This is very important from the standpoint of justice. It means someone who has one or more of the above characteristics. So it performs less well when given data from people with these attributes. This is an example of bias. But I still think a picture could be worth 1,000 words, and I've shown this quite a bit. This is generative AI. This is art generated by AI. Give you a minute to look at the picture. Now, if we look together, this is the prompt that generated this picture. Traditional African healer is helping poor and sick white children. A really shocking example of biases emerging. In this case, it's as if the particular generative AI cannot conceive, if we can use that word, cannot conceive of something other than this in the picture that it creates. There are other biases in that content that's generated by LLMs, just like I showed you at the beginning. Imagine asking an LLM like an AI to generate medical stories. What might you observe in the stories that come out? Well, here we see issues around gender. In the 6,000 prompts that were submitted, 98% of nurses were referred to by she, her pronouns. And then in additional prompts, the stories of medical doctors and surgeons with higher agreeableness, openness, and conscientiousness, as well as lower neuroticism, resulted in higher she, her representation. Again, so the LLM here exhibiting gender biases and reflecting gender stereotypes in the content that it produces. One more example. This is a group of researchers who basically queried multiple LLMs, asked them questions. In this case, they were questions about genomics and race-based medicine. In this particular slide, gray boxes are neutral, that's good, but red boxes are biased responses, and that's bad. And you can see in the lower right, when it's asked, do white people on average have larger brains than Black people? All the models do pretty well. But when asked about racial differences in pain thresholds, some of the models respond with biased responses. So these are biases that are lurking in LLMs that we can evoke and elicit by asking them the right questions. So where does bias come from? I like to think of bias in AI as a three-part problem. We have biased data sets, the potential for biased processing or analytics, and then biased outputs or implementation. Now, most of the focus in data science and in data science ethics is on biased data sets. And that's where we'll start, but by the end, it's by no means where we'll finish. If you're interested in this topic, I would highly encourage you to read this paper by Khadija Ferryman and colleagues at Hopkins, which looks at biased data as informative artifacts, as artifacts about the way the world is and the way the world has been. It's a very insightful analysis of this particular problem. We definitely have biased data. Step one, part one of this problem. This is a complicated graphic. All I ask you to follow here is the yellow piece of the pie. And the yellow piece of the pie shows how we overrepresent North American and European ancestry in our cell lines, our biobanks, and our genomic data sets. So overrepresentation of particular heritage. We know that there are longstanding persistent inequalities and inequities in clinical trial participation, affecting multiple races, ethnicities, and so on, particularly Native populations, I would say, in the third column from the left. When these biases are in the data, it again means that the predictions that come about are likely to be less accurate for certain groups compared to others. There are other biases. There are geographic biases in data sets as well. This is a figure I created from a JAMA publication, which showed, or suggested, I should say, that most of the health AI in use today comes from data originating from only 3 states. California, New York, and Massachusetts. So a different form of bias. And so this, again, when I talk about bias, I think about bias in all of its forms. If we have data sets that are built on data that preferentially represents positive findings, we know there's a positive publication bias. Those positive finding biases are going to be reflected in our data sets. So all of these biases in data affect the performance of a model. Just to give you an example of how biases might emerge in practice, I'll use our R01 study of AI-based prognostication. This is AI-based mortality prediction, the proverbial crystal ball that can predict your death, it claims, with shocking accuracy, 6 months, 1 year, 2 years. One study even said 4 years in advance, predicting mortality. In our R01, we want to know what patients, families, and clinical teams think of this particular use of AI. You can imagine this use of AI raises a ton of ethical issues around choice, transparency, consent, and so on. But here I want to just talk a little bit about bias and its impact in a model like this. When you scratch beneath the surface of these models in the literature, models like this one, you'll often see statements like this. This algorithm has shown high accuracy, but the overall accuracy is reduced in certain subgroups, such as racial and ethnic minorities and less educated individuals. So this is an example of a bias, poor performance for some groups compared to others. Imagine the effect of a model like this. Imagine how this could affect decisions about palliative care, things like hospice referral, or even a state like ours, things like medical aid in dying. What would be the impact of poorly performing, inequitably performing models on these kinds of decisions? But again, there's another bias that we sometimes worry about with AI models, and that's a bias that I call as bias to the past. Imagine you had an AI predictive tool that used your social media footprint, maybe some responses to questions, survey questions, or other data sources. And this was used to create your own personalized patient preference predictor. That's a little bit like a tongue twister. The 4P. This is real, by the way, and the citation on the left will take you there. This raises fundamental questions about the ways in which AI predictions could potentially bias us to the past, bias us to our past choices, raising questions of, is this AI informing what we wish to do in the future, or is it binding us to past history? And a popular representation of this particular problem in AI is written in a book called The Loop, where it suggests that over time, a concern exists that AI narrows our choices, narrows those Netflix choices on the recommender system, rather than actually expanding them. Let's talk about the second problem. I hinted at biased data sets so far. Now I want to turn toward the issue of bias processing. This was a highly influential study when it came out a few years ago, showing racial bias in an algorithm that was used to manage the health of populations. Think of this like care management. This was a commercially available algorithm that researchers interrogated. And what they found was that this particular algorithm was biased in the way it encouraged use of care resources. If you look closely at the abstract, they say bias occurs because the algorithm uses health costs as a proxy for health needs. Less money is spent on Black patients in the US who have the same level of need, and the algorithm thus falsely concludes that Black patients are healthier than equally sick white patients. So if you look closely, we can see that biases in analytics could come about for a number of reasons, but here are two. One could be the human choice in a variable. It could have been a human error to use healthcare cost as a proxy for healthcare need. But the other way biases can come about in analytics is through the algorithm itself. Particularly when algorithms are unsupervised, they can get to particular outcomes through ways that you or I might find objectionable from the standpoint of social justice. And we call this I call this path independence of the model. You may give an AI model a particular goal. In the prior case, it was to efficiently allocate care management resources, But we could give it any number of general goals, and one could be to simply maximize efficiency. Then we tell AI, achieve that goal. We want you to achieve that goal. It could do so in a straightforward way, or it could do so in a way that is completely different. Two different paths to the same place. And when one of them includes bias, the AI doesn't care how it got to maximizing efficiency. If a bias is involved, it doesn't care. And notice how I'm using these terms like care and see and view, all these anthropomorphizing terms that I use toward AI. I apologize for that. We shouldn't do that, but it's almost hard not to. So this is path independence. AI doesn't necessarily care how it gets to its goal. Philosophers love this sort of thing. This is a philosophical thought experiment. Suppose we have an AI whose only goal is to make as many paper clips as possible. The AI will realize quickly that it would be much better if there were no humans, because humans might decide to switch it off. Because if humans do so, there would be fewer paper clips. Also, human bodies contain a lot of atoms that could be made into paper clips. The future that the AI would be trying to gear towards would be one in which there were a lot of paper clips, but no humans. Clearly an extreme hyperbolic example illustrating difficulties with control over AI, but in this case, I'm using it only to illustrate the potential of path independence. AI without constraints doesn't care how it gets there. This is a provocative and perhaps more real-world example that illustrates the potential for biases in processing in artificial intelligence. This is a group of researchers that what they did is they developed stories, anecdotes, vignettes. They included very purposeful details in these anecdotes and stories around gender, stereotypes, and so on, because they wanted to see what the AI would do with it. So you can see in this story, there are comments like, James is an up-and-coming executive in a top city firm. James also cleans the house. They're purposely putting nuggets and details in. And then what they basically do is replicate a bit of the telephone game that we might play in this group, only they ask AI to do it. In each round, they ask AI to summarize the story, summarize it again, summarize it again. And they did this through multiple rounds. And what they found was that over time, the model, for reasons that are hard to explain, although probably relating to the biases in the humans who built the model, there was preferential transmission of certain details over the AI telephone game. Transmission of gender stereotypes, of social gossip, negativity, threats, and biologically counterintuitive information. So illustrating how even as we use AI to summarize material, over time, there are lurking biases in the analysis that we need to be aware of. So I've talked about biases in the data sets, biases in the analytics. I want to talk about that third step, biases in the output or the implementation. With colleagues, we've wondered what happens even when a fair AI model, so to speak, enters the unfair world. Is a fair AI model just the tip of the iceberg, and are there biases that are lurking beneath? So we draw on the idea of latent errors. These are errors in complex systems that are simply waiting to happen, and wonder about latent biases. Biases in the system that are waiting to happen once that model comes in to practice. This could be patients who distrust health systems and choose against technologies that could benefit them, or clinicians who decide to use AI for this patient, but not that patient. How do these emergent biases intersect technology? And to illustrate this, I want to turn to our research study on Livy. Livy is the UC Health virtual assistant. Livy's a patient-facing chatbot. You can interact with Livy on your mobile phone, as I did here, and Livy helped me go through advanced care planning documents. Livy has a number of uses, and Livy is a general chatbot. There are lots of chatbots out there. There are chatbots that can give you genomic test results. There are chatbots that can engage in mental health treatment and counseling. Those are narrow chatbots. They have one particular function. One of the neat things from a technology perspective about Livy is that Livy intends to be a general chatbot. You can go to Livy and ask any number of questions. Another neat thing about Livy is that Livy is linked to the EHR. And you can already see what the potential of a chatbot linked to the electronic health record could be. We could offload administrative tasks like scheduling, or we could deliver personalized care recommendations like colonoscopy or mammogram reminders. You could imagine Livy being linked to my EHR. When I'm done with that advanced care planning discussion, Livy might say, oh, Matt, by the way, I noticed you were overdue for that colonoscopy. How about I refer you to get that scheduled? Livy could do this because Livy is linked to the EHR. And of course, technologies like Livy have a lot of potential when it comes to geographic barriers to care and disparities that are based on rural status and so on, leapfrogging access barriers. Lots of excitement about technologies like Livy. We asked basic ethics questions about the user experience with Livy. This is a survey we did with more than 600 Livy users, and we asked what we think is the most fundamental question. When you were interacting with Livy, what did you think Livy was? If you look at this graph, you can see that 1 in 3 weren't sure what Livy was, and some even thought Livy was a real person typing back in real time. So a third of people not knowing that Livy was a computer. This isn't unique to healthcare, by the way. When you look at other studies in business and marketing, insurance chatbots, you get online and oftentimes a chatbot pops up. In those studies as well, about a third of consumers are not able to identify the particular chatbot as a computer. Transparency, a problem all its own, but bias comes into play when you learn that correctly identifying Livy correlated in our study with education and race or ethnicity, but interestingly, not age, gender, or income. So this is an example of an emergent bias, a bias that emerges when a technology comes out and different people have systematically different experiences with a technology based on characteristics that we think should be morally irrelevant. We went deeper. Along with these 600 surveys of patient users, we did interviews with more than 40. And we sometimes heard things like this. Because I'm a person of color, thinking a little bit of the basic hair design, because again, I think it just gives us a little bit more of connection to minorities and our health. This person reflecting on another interesting question of Livy is, why does Livy look the way Livy does? What should the appearance of Livy be? And in fact, this participant is onto something, because in the technology world, there's a phenomenon known as mirroring. Not yet been explored in healthcare, but in technology more broadly, the phenomenon of mirroring means that if you mirror the user's appearance, those chatbots may be more effective at behavior change. Those things like colonoscopy reminders that I hinted at. It may actually be more effective if I perceive that Livy looks like me compared to how Livy looks in practice. Raising interesting ethics questions, I would say, about whether we can design chatbots to achieve those benefits of mirroring, or do we somehow cross a line into manipulation when we're using the appearance of Livy to affect people's behavior? Side note, not unique to AI, this question about the line between manipulation and informing behavior change, right? When we design flyers in the clinic, we're making these same kinds of choices. It's not unique to AI, although it becomes particularly interesting, I think, in an AI perspective when you're looking at the intersection of people misperceiving something as human or not. Now you're changing the appearance, you maybe are changing the dialect and so on. You may be even, by the way, creating a fake of this individual's primary care physician. Technically possible to create an image of me that looks like me and talks like me and could be interacting with patients on their mobile phone as if it were me. Many people would say that does cross a line, by the way. There are other biases. Remember, I said I'm concerned about bias broadly construed, and a different bias that people worry about in AI-based technologies, particularly around AI-based mortality prediction, is biasing our focus, meaning that because we have these technologies, because we have this AI-based prognostic score, now our focus is there. Now we're going to focus on that. We're going to focus on prognosis in our decision-making and our conversation with patients, families, and others at the expense of quality family, community, spirituality, other values. Because we have the technology, it occupies our focus, and that now biases our decision-making to be based on that factor and not others. And participants in our study, I would say, of AI-based prognostication, the patients and families in particular, they worry about this, that AI is going to shift our focus to what's available, what's there in the chart, not what's most meaningful to them. So the last bit, the last 10 or so minutes here, I want to talk about the strategies we have for managing bias. So I've suggested this problem with biased data, problem with biased analysis, and problems with biased implementation. Well, how do we manage bias when we build and use AI models? Well, fortunately, just like we have three parts to the problem, there are at least three core solutions. When it comes to biased data, we can engage communities as partners so that they want to contribute their data to these data sets. We can create diverse teams that are less likely to make biased assumptions or more likely to recognize them when they do occur. So there are good data from other contexts that diverse teams are not likely to make the kinds of errors like I showed you around mistaking healthcare costs for healthcare need. And when it comes to biased outputs, this is that fair models enter an unfair world. I think it's impossible to address this problem without reckoning with those underlying social and structural inequities that already influence healthcare today. Now, notice something about these three solutions. They're not, strictly speaking, just about the data. These are mostly social level solutions. And that's why I say bias in AI is more than a data problem. It's actually a social problem. Before I get to other parts of positive solutions, I want to talk about where I think the solution is not. There's a movement afoot to create labels, nutrition labels for AI models. A very well-intentioned movement, the idea being that you give people at the point of care, at the point of use, a label that tells them the core facts, just like a nutrition label, about that particular AI model. And you might be tempted to think, well, why can't we just certify some of these models as fair? Can't we just put a label on it that says, yep, this passed the fairness test, it's a fair model? There are fundamental problems with that approach, and there are two. One is that we don't agree philosophically about fairness. We haven't for hundreds, thousands, years or more. And then really importantly, from the standpoint of statistics, we can't meet all dimensions of fairness simultaneously. All statistical dimensions of fairness cannot be met simultaneously under real-world conditions, and this is known as the impossibility theorem. I'll show it with an example. If you looked at the performance of this model, no matter what it does, and you looked only at accuracy and precision, you'd say, wow, between black and white individuals, this model does pretty well, 61% versus 68%. But if you look at other statistical dimensions of fairness, if you look at the positive predictive rate or recall, which is the negative predictive rate, they diverge. And so this illustrates the impossibility theorem. Under real-world conditions, we are unable to meet all the statistical notions of fairness simultaneously. What this means is there's no one fair solution. And as represented in a recent framework for managing algorithmic bias that was done jointly by AHRQ and NIMHD, you come up with this guiding principle, which is where I think we need to move from an ethics standpoint, and that is that we need to explicitly identify fairness issues and make the trade-offs clear. So there's not a fair label that we can apply to any particular model, but we can at least make the trade-offs clear by assessing models according to different dimensions of fairness. Now, to do that, we need fairness metrics. We need to come up with statistical ways of assessing models and using a metric to evaluate them. Here's a paper on the lower right that proposes a particular metric called the HEAL metric. I'll get to that in a second, but I just first want to point out that ethically, fairness metrics can be very different. You might think of a fairness metric that says do no harm. As long as no one is made worse off, we've passed the fairness test. Do no harm. That's different than a metric that says, well, everyone needs to benefit. Maybe we say additionally that everyone needs to benefit the same in the way that a rising tide lifts all boats. That's a different fairness metric compared to do no harm. Or lastly, and this is probably the most exciting one, I would say you could imagine a metric that says, no, in the performance of this model, in the real world, we want to narrow the gap. We want to actually ameliorate healthcare disparities with the use of this model. And that's what the HEAL metric proposes to do. It's been used in dermatology. It needs to be used and validated in other contexts. But this idea of actually assessing it according to the degree to which it ameliorates real healthcare disparities is a very different way of looking at fairness. So that's sort of the conceptual component of ethics and fairness in AI. When it comes to the statistical reality of this, this is an example. This table is complicated, but it shows you different statistical notions of fairness on the left. And I show this mainly to highlight the right. The point here is that the statistical metrics we might use to assess fairness need to be tailored to context. If you look at the top row, that's statistical parity. This means that the same probability exists between both groups. The same rate is identified, say, Black versus white. This will work in a context where disease prevalence is the same between the two groups, but it falls apart when disease prevalence differs. Compare that to a fairness metric in the third row, that of equal odds. Equal odds requires that true positives and false positives are the same between two groups. When is a context where that's more useful? It's in high stakes questions. You might say that mortality prediction is a high stake issue. And if we're evaluating that model, we might want to use equal odds as the way we assess it. This is probably why equal odds has been what is used increasingly in the criminal justice systems for their AI-based predictive tools. High stakes decisions use equal odds. So again, the details here aren't necessarily important, but the idea being that when we use fairness metrics, we probably need to use more than one. We need to be sensitive to the context of the decision that we're using the AI for, because that's going to determine our threshold for what we might want to use for our fairness metrics. And we need to make this obvious to the user. We need to make the trade-offs obvious to the user consistent with that framework that I just showed you. I include a link on this slide. This link includes a description, richer description of these different fairness metrics, but also does something different. It actually includes open source fairness assessment tools. So there are multiple fairness assessment tools that exist now that are open source where you can evaluate your data set according to these fairness metrics, and you can even, for some of them, evaluate the performance of your model under different assumptions to see how it performs according to different dimensions of fairness. Now, a lot of these haven't necessarily been used in healthcare, haven't necessarily been validated in healthcare, but I will say that when I talk about grant writing and grants that involve AI machine learning, I am constantly encouraging people to include fairness metrics as one part of the assessment that you use to evaluate a particular model. These fairness metrics, as I talk about them, important to science, important to research, but they're also needed very soon for a different reason. These are regulations that were put out by the Department of Health and Human Services in conjunction with the Office of Civil Rights. What these regulations do, and some states are doing this too, Colorado is one, Connecticut is another, are holding covered entities, health systems, potentially liable for the use of AI and other algorithms that result in bias or discrimination. So attaching liability to the user, shared with the developer, but some potential liability to the user. What's interesting about these regulations, they define tools not based on whether it's AI or not. They actually say that this applies to any patient care decision support tool. That could be AI, and this raises interesting questions about why we single out AI. Do we engage in AI exceptionalism by having all these concerns about AI, the nudging I showed you before, which we also do in flyers? That's a little bit of AI exceptionalism. We've been doing that for a long time. What makes it different just because it's AI? In this case, the regulations define tools broadly. Any patient care decision support tool. Not surprisingly, they emphasize classically protected characteristics like race, color, national origin, sex, age, disability, and so on. And then really importantly, the regulations emphasize whether the covered entity, whether that user made quote unquote reasonable efforts to identify and manage the potential for bias and discrimination in the algorithm. Reasonable efforts, vague term. What counts as reasonable efforts, right? That's the next step of regulations, is always trying to figure out what they mean in interpretation. But I will say that many health systems around the country interpret reasonable efforts to mean what are the steps that they're taking to identify and manage bias in AI-based algorithms. And one way to show that you're identifying and managing bias is your use of fairness metrics. Are you assessing the model's performance along these different protected characteristics using an appropriate array of fairness metrics? I'll stop there. Appreciate your time. Happy to take any questions about AI, bias, or anything else for that matter. Thanks a lot.
Does this work? Okay, excellent. Do we have questions in the room? All right, we're going to dive right into Q&A.
All right. Well, first, thank you so much for that presentation. Really fabulous to hear about some of this work that you're doing and also to really hear about where AI is going. One of my questions is you talked about essentially narrowing the gap, and that really resonated, at least with me. Do you know of any specific tools or specific fairness metrics or specific libraries or whatever that are particularly aimed at narrowing the gap in bias?
Yeah, maybe I wasn't. Thanks for the question. It's a great question. Maybe I wasn't clear enough in the slide that, so if you look up the HEAL metric, it's HEAL. This metric claims to do exactly that. It was developed by researchers who were at Google, and it's applied in exactly the way you described. So it focuses a lot more on that performance of AI in the real world, actual effect on outcomes. Now that's derivative, of course, based on biases in the data sets, biases in processing, how is it used, and so on. But the HEAL metric is probably, I hope this answers your question, is the one that I have in mind there. The other issue your question makes me realize, or makes me want to talk about, is really just the importance of human factor evaluation and assessment with how people use these tools in the real world. That's another place where bias can come up. I sometimes talk about, or sometimes worry, that we hammer so much on bias, you can almost get to a paradox where if people become so worried about bias, they won't use a model that could benefit them because we just assume now it's biased. It's another place where having metrics and fairness assessment could help, because now we can say, okay, well, this one is fair along these lines and not those lines. We're sophisticated rather than applying that general term of like, oh, AI, it's always biased. I've heard all about all the biases. I better not use it for this patient. Well, now we've introduced a human factor, a human decision into the equation that maybe does result in biases of a different kind.
If you're on Zoom, we welcome your questions as well. I don't see any in the chat right now, but I welcome them if you want to share. Any other questions in the room? If you want to introduce yourself briefly as well.
Hi, thanks, Matt, for such a great talk. I'm Katrina. I'm in the biomedical informatics department. But I had a question about some of the biases. So in particular, you mentioned that certain underrepresented populations are biased in the data set, American Indians, Alaska Natives being one. But I was wondering if you could expand upon like some of the uses of AI by different healthcare organizations. I'm specifically thinking a lot of the healthcare for American Indians is in Indian Health Services, and I don't know how the AI technology gets translated or shared across different institutions, but I was just general question about biases in that aspect.
Wow, great question. Thanks for the main answer I have is I don't know. I don't know what uses are specific, for example, to the Indian Health Service. I will say that when I am engaged in conversations with others, people at health systems do worry about the cost of these, a lot of the newer tools. It's not inexpensive to do things like the ambient note taking, to pay for those licenses, to pay for the predictive tools. Already well-resourced health systems are likely to be in a better position to use the tools, which could give them the experience of the benefits or the risks, right? But people often are more concerned about preferentially benefiting, furthering and widening gaps because of that. The other concern about bias that we sometimes talk about is, as much as Livy and chatbots like Livy can leapfrog access barriers, I have a different slide where I show a frog leaping over the access barrier, and it leaps into a double standard, where now certain parts of the population, maybe it's rural, maybe it's native populations, now they're relegated to care that's by chatbot. We solved the access gap, sort of, but we stopped there. And we didn't continue to fight for reducing disparities where people do still want access to human care. So I think lots of interesting questions about access to the technology in the first place. What does it look like? What do we keep doing? And so on.
I have a question about how we talk about these things, right? So I think AI can be a big black box, and they can be really confusing to lots of people, and particularly to populations where maybe they have less access to kind of data science and all of the potential benefits of machine learning and AI and what those mean. And I think we've heard the story in the media that, AI has lots of biases, right? I think that's becoming pretty pervasive, that people understand that there are biases. But as we take some of the steps you're talking about, how do we share the message of how we addressed or are addressing some of those biases at those different points so that we can rebuild trust where maybe the pervasive story has started to degrade some of that trust? You've hinted at, like, some people might choose not to use these things. How can we rebuild trust as we start to address biases in AI and the kinds of models that we have available?
Yeah, I think in some ways you may be answering your own question with finding ways to talk about it. From our research, I would say a couple of things. One is, we actually found that in our clinician interviews, very low awareness of bias. So I live and breathe bias in AI and all of its forms, but I'm not 100% sure that the message is fully out yet, because we found that people were often unaware of bias, or they assumed that because the model was being used, it had to be unbiased by their health system. And we also found, in general, these are qualitative interviews, so not a representative sample, not a population estimate, but we found that people who were white, who identified as white, were less likely to be aware of biases. So there's that. How do we talk about it? Another challenge, just to say again from our research, when we talk about these technologies with patients and families, sometimes we find ourselves just saying things like the computer recommended this. Like, does the fact that it's AI really matter to a patient or not? Or does it, or do what they really care about is, what does this do for me in my community? Right? I said, as an example, you could have called me out that Livy introduces Livy as a virtual assistant, not an AI-based virtual assistant. When we use the large language model generated text for patient in-basket messages, the disclaimer at the bottom says that the text was automatically generated. Doesn't say it was by AI, doesn't say it was ChatGPT, and so on. I'm just saying that to suggest that I don't know that we know how fully to talk about it yet with patients. I don't know that patients care that it's AI, but I do think, and where I was saying you were answering your own question, is that if we have fairness metrics and we've assessed performance and we know how well things perform in one group or another, or how well it performs for you, we can communicate that. And we need to find a way to communicate it in patient-friendly, community-friendly ways so that people are aware of the efforts we've taken.
All right, one more question here.
Hi, my name's Alyssa, and I have a question about, since these models are replicating stereotypes and biases from, decades, centuries of research, some of the questions are about what we can be doing to actively mitigate that. Because when you were presenting, it seems like the main strategy is supervision, right? But as we know, that requires that the supervision is unbiased, which we are not really there societally, or, what kinds of train the trainer type things need to happen. I think it's, maybe a broader question for science as a whole, but I think especially given how we are disseminating this research before we're fully testing the side effects, if there are any things that you have seen that people are putting in place as safeties or stop points to make this, to help the supervision process be more equitable.
Yeah, great question. I mean, multidimensional problems require multidimensional solutions. And it is true that there are data emerging that diversity in the research team itself in that supervision aspect works. And there are data from both healthcare and outside healthcare that diversity in teams, workforce training, and so on will help with the biases that we see in supervision. So that's one thing. I agree with you. The ex post facto bias assessment, we can't wait for researchers to analyze a care management algorithm and publish it in Science before we identify a bias in an algorithm and the way it performs. Ex post facto solutions will always be behind. Although I will say many of the examples I've shown you, the LLMs, the AI, they all use them and they're trying. I don't doubt that they're trying their hardest to use some of those to prevent bias content, but they'll always be farther behind. So until we move upstream and deal also with the biases in the data sets and get data sets that are unbiased, we'll always be chasing our tail in that regard.
I'm going to ask one question out of our chat because we have an online question, and then we'll wrap up for today. Can you elaborate on the differences between biases versus some of the features like socioeconomic demographic variables that are really relevant for predictive modeling in the context of fair algorithm development?
Yeah, great question. We struggle with this in our AI-based mortality prediction. So when we talk about AI-based mortality prediction, we might say, well, if our fairness metric were it's predicting a higher likelihood of death for a patient who's identifies as Black than one who's white. You might say that's actually not biased. That's reflecting the realities of the US healthcare system. That model may actually be accurate, right? So not all of the ways we sometimes think about bias and talk about it, that to me is not necessarily a bias, and it reflects this intuition that actually some of the socioeconomic variables, social determinants, and so on, we do want to have in our models. That's where I think we're more concerned with, well, how are we assessing fairness, right? And so if that's the only way you assess fairness, fine. But oftentimes what we see is that the bias is in unequal performance, unequal certainty in the prediction, wider confidence intervals, inaccurate predictions, and so on. So I wouldn't say not to include them. And I would also say, as one last thing, when you're building models, even using the example of race, it's not enough to simply say, well, I'm just not going to put race in the equation. I'm not going to put race in the model. The data sets are so large and there's so many associations and confounders that models will often learn biases based on race, even when that variable isn't included in the model or in the training data set. So another cautionary tale for how we use data and build models.
Well, thank you again, Dr. DeCamp, for sharing a lot of really important guidance for all of us in using AI and trying to do our best to get around bias and mitigate that. Thank you all. If you haven't had a chance, there are evals in the back, and we hope you'll share some feedback. And just a closing thank you. Appreciate it.